Well, speaking as a patient on behalf of other patients and caregivers, it's really terrific that you folks are here. We really appreciate it. We know you're experts in your field in these particular areas, and you're really leading the research. So we're delighted to have you here to help us understand where things are going and sometimes even just how to manage some situations that we have. So, well, why don't I just pick a random question from those submitted in person here to start with, and that is, do you have any pointers for getting into a clinical trial without measurable growth outside the CNS? So if you've got progression in the body, not in the brain, any particular tips for getting into a clinical trial? It should be an easy question for starters, right?
No, and unfortunately that is a very tricky situation, and we run up against that quite a bit. Almost all clinical trials will require measurable disease in the body. We call it the system RECIST. You might sometimes hear us say RECIST or RECIST. It just means that there has to be a target lesion in the body that we can measure and then follow as you go on to the drug. And it's really the traditional way that we've always followed efficacy of drugs in clinical trials. Many, in the past, a lot of phase 1 trials did not require measurable disease early on, but nowadays, because there's so much anticipation about activity, even the phase 1 trials are oftentimes requiring measurable disease in the body. And unfortunately, if that's in the eligibility, there's really no way around that. Do you want to add to that?
Yeah, I mean, again, this is where I think you have to be creative and employ other treatment strategies to perhaps treat the disease that you do see. So if there's progression in the bones, radiation is a reasonable way to alleviate pain. And although it seems odd, by treating that, it may allow something in the lung or liver or other place to show up as measurable disease later that we could then use. Also using chemotherapy, again, to control the disease for some time, and then hopefully if something does progress, it'll be in an area that's measurable. So you can, again, use kind of these alternate strategies that might not involve a clinical trial.
The next question I have is something that I've heard come up on Inspire and other forums a couple of times before, and you might have a slight difference in your opinions on this. For ROS patients, Alice, in your last slide, you listed a couple of experimental drugs that are being pursued. Are those the only options for a ROS1 patient? Or are there any other drugs that might be currently available by prescription, for example, that you might consider in some cases giving to a patient? Maybe a patient who doesn't have the option of being eligible for a clinical trial. So first, let me start with you, Dr. Doebele.
Yeah, so I think one thing that's important to consider is that these drugs do not have kind of near equal capacity in treating each of these. So although ceritinib is a slightly more potent ALK inhibitor than that crizotinib is a slightly more potent ROS1 inhibitor than ALK inhibitor. Ceritinib is actually the opposite. It's slightly more potent against ALK, and so they're not always equivalent. They're very similar oftentimes. And again, a lot of the drugs that we use in the second generation ALK setting have really no activity against ROS1, so we have to be careful that those may not work. There's been some preclinical data that ferretinib, for example, may have activity. It's not FDA approved. It was supposed to start clinical trials, but that drug is not currently under development that I know of.
That's what I had heard. They discontinued it, but do you think that's going to stay that way?
Well, it had been, yeah, I think that was a business decision by GSK, so it's no longer at GlaxoSmithKline, and so I think we'll have to wait and see if the company that originally made it, Exelixis, will go back and revisit that. It looked promising in preclinical models and maybe overcoming the 2032R in the laboratory, but I think we'll have to see.
Okay. Alice?
So I think the issue, many people ask about using ceritinib because it is commercially available now and trying to use it off-label for ROS1. Actually, even in the FDA label, it's mentioned that ceritinib may have activity against ROS1. That's all based on preclinical data. And as Bob was saying, unlike the ALK paradigm where you're going from crizotinib to a more potent ALK inhibitor, for ROS, crizotinib already is really, really potent. And so going to ceritinib, at least in our lab, we really don't see any difference in potency against ROS between criz and ceritinib. So I don't know how well ceritinib will work in the setting of resistance in ROS, and in addition, there really is no clinical data yet. There will be a clinical trial looking at ceritinib in ROS, but we don't have any sort of results on that. So again, we just don't know if ceritinib will work at all in the setting of crizotinib resistance. As I mentioned, PF3922 does seem very active against not just ALK, but also ROS1, and at least, again, in the lab, does look like it may be able to overcome the highly resistant ROS1 G2032R mutation. So I'm sort of excited about testing that drug and seeing how well it works. And then the other thing to think about, if you are someone on crizotinib and you have ROS and you are wondering what your next step could be, and as we mentioned, chemotherapy is always an option. If you haven't been on chemotherapy, in particular, adding, for example, pemetrexed and carboplatin to your crizotinib is something that we often do as well. And we do see, just as with ALK, for our ROS patients, we often see very good activity with pemetrexed.
Very good. If you've got a patient who's doing well on crizotinib, no progression in the body, but then brain mets, what are your thoughts on, of course, some treatment for the brain mets typically, and then would you go on to a second generation ALK inhibitor in that case, or third, or would you continue the crizotinib? We saw some earlier slides that suggested sometimes sequential duration combined can be longer. So that might be a factor that you consider too. So what would your pattern be when you've got a patient on crizotinib, doing well, brain mets, treat those, what would you do next? Dr. Doebele?
Sure. So if it's only brain metastasis, I would definitely favor radiation. Now, one problem is if there are only a few sites, you can do stereotactic radiation, so kind of pinpoint radiation for multiple lesions, and that can be often repeated if new ones crop up. So I think that's a very reasonable strategy. Again, if you're not seeing progression in the liver, bones, or lung. Whole brain is another type of radiation. Typically, well, there are exceptions. That's only given once. There are some radiation oncologists who will try that again if it's been several years. And
then what about after the treatment then?
No, I would continue crizotinib until there's more widespread progression in the lung, liver, or bones in those cases, typically.
Dr. Shah?
Yeah, so it very much depends on the type of relapse in the brain, and as Bob was saying, a single site, a couple of sites, we often will use local therapy and continue the crizotinib. But I think, unfortunately, we run into this problem where patients have already had radiation, whole brain, they've even already had gamma knife, and they're on crizotinib and relapsing in the brain, and that's a trickier situation because we don't have radiation as an option anymore. And so in those patients, even though the rest of the disease might be stable, I have been switching those patients to brain-penetrable ALK inhibitors like alectinib. And alectinib, as you saw, has really, really good activity in the brain.
So the two drugs for both of you, the two most useful second-generation inhibitors for dealing with brain mets, which do you think that they would be of the given leading candidates? And you can include the third-generation drug that you know of in that list. So Alice first.
Well, both ceritinib and alectinib have shown brain met activity, but as I said, the data with alectinib seems to suggest that alectinib has better penetration into the brain than ceritinib, and certainly better than crizotinib. So again, it kind of depends on the patient, but if I have a patient who has really just the main issue is CNS disease, they're relapsing on crizotinib with that, these days, if I can, I will encourage the patient to be on a trial of alectinib.
I think at this point we just know a little bit more about alectinib, right? So for this, I think it's really important not just to get a response, right? I think all of us would argue that if you got a response and it only lasted a month, just to make up a number, that would not be particularly useful. But if you get a response and it's ongoing for 9 or 10 months, or hopefully much longer, that would be better. And I think really the drug that's starting to actually give us that data is alectinib, where we're seeing long-term responses. I think once we see the numbers from the other ones as well, and I think, again, it's not just going to be do they respond, but how long do they respond? Alectinib looks very promising. The PF3922 looks very promising in animal models. I think you really just, until you start putting it in patients and you see what happens, it's hard to know whether that's going to translate or not.
The PF3922 is a very good drug. Even clinically, we've been testing it, but we're still in the dose-finding phase, so we don't have the right dose. We're still, of course, working out all the side effects as well. So again, as Bob was saying, alectinib, we just have a lot of data on it. We probably have the best brain met data for alectinib so far, but there'll be more to come.
In the interest of time, I think I'll limit us to like 2 more questions. One more? Okay, well, first, is there any further information on the research for the why it is you think Alimta pemetrexed seems to be more effective in ALK? Have you analyzed something unique about ALK that does that, or its bypass mechanism somehow being involved? Or do you think there's some other factor that might just happen to show up a lot in ALK patients?
So I think I think we don't fully understand it. I mean, one of the really interesting experiments that we did, and again, it's a very complex signaling pathways in these cancer cells. But one of the experiments we did is we actually put the ALK gene into another cancer cell line and made them sensitive to pemetrexed, suggesting that it actually reprograms the cell to perhaps be more dependent on these pathways that pemetrexed hits. I mean, as Dr. Pennell said, pemetrexed is a targeted drug. It hits thymidylate synthase. It actually hits a number of other targets as well. Unfortunately, those signaling pathways are very complex and intertwined. I wish we knew a little bit more. I think there is a real relationship between the two, although I don't think it's absolute. I mean, there are other patients that benefit from pemetrexed. Not every patient has very long-lived time on pemetrexed. Again, interestingly, we've noticed the same thing in our ROS1 cell lines in the laboratory, that they're exquisitely sensitive, and there's some scant clinical data, but clinical data that suggests those patients do better as well. So I think it's a real association. I wish I knew exactly why.
Not much other than that. I mean, where we've seen as Bob mentioned, we can't always, it's not 100%, so it's just more like a trend. You know, ALK patients tend to be, more responsive to pemetrexed, and definitely ROS1 patients in our experience as well. And actually at our institution, it just seems like never smokers with adenocarcinoma, regardless of ALK or, ROS status, are a little more sensitive to pemetrexed, but why exactly, we don't know.
Last question, it's a short one, which is, we've made some wonderful progress with first and second generation drugs for ALK and ROS. When there's a new mutational variant or an amplification, we're finding ways to address that. But you've also identified that there's also bypass mechanisms, other ones. Do you think the future is also bright for being able to find ways to control that type of resistance in general?
Yeah, absolutely. I mean, I do think that we're probably going to, at some point, hit diminishing returns with more potent drugs that overcome all mutations. And we know that cancer cells are very adept at turning to other signaling pathways. And I think it's a little bit harder to study. I mentioned the lamppost, and one of the reasons that we've focused on mutations is because it's a little bit easier. We are working on ways to try and detect these other signaling pathways that sometimes get activated without a genetic mutation, to try and target those as well.
Yeah, no, I think it's very exciting. As you saw, there are many combinations that are coming, and that will be really to address this problem that we will eventually probably run up against, these ALK-independent mechanisms of resistance that we need to target.
Excellent. Thank you both, and I want to make sure that everyone has a chance to show their appreciation for these two researchers and the teams that they work with. There's been excellent research that these folks have brought to us and made it possible for us to live longer. So let's give them a good round of applause here.